This is meeting 2B, applying quantitative methods for evaluations on a large scale.
I don't know if they're going to bring people in from outside.
Yeah, but yeah, and we have a good student on the front row. Yeah. And there will be 3 presentations: one by Erin Ben-David from Stanford University, one by Charlotte Watts from the London School of Hygiene and Tropical Medicine, and one from Rachel Nugent from the University of Washington. Now, so far we've talked about methods mostly in a retrospective kind of sense in terms of the Global Fund, PMI, other evaluations. Just recently, the session before this one was more about evolving methods of research. And in this session, I suppose we're going to get more of a statistical view, a quantitative view of how to conduct evaluations. But I'll leave it to the panelists to do their presentations. They'll each take about 15 minutes, and then we'll have a discussion and take it from there. Iran?
Sure. Okay, great. Thanks, everyone. It's a pleasure to be here. It's a pleasure to be part of this group. I am going to apologize ahead of time. There's this combination of jet lag and caffeine and a mild cold, so any incoherence is my own. But what I was hoping to do a little bit is sort of challenge some of the previous constructs and conceptions, but some of them have already been touched upon. But I'm still going to try to sort of push gently against some of the ideas that have been put up there. So we talked a lot about possible outcomes. I'm not going to go through these too much, but these large evaluations can sometimes examine the operational outcomes, how the organization is set up, the output outcomes, such as how many grants are being dispersed, the health proxy outcomes, such as delivery of vaccinations and bed nets. And then there are health outcomes, and the health outcomes is really where I'm going to try to sort of focus mostly both on their measurement in the present as well as their measurement in the future, some potential opportunities of what things could look like as we're moving on to the possible suggestions and recommendations from this meeting. So in the health arena, we are pretty fortunate to have sometimes very well circumscribed final health outcomes, whether it's mortality or all-cause or disease-specific incidence and prevalence of disease and quality of life measures that are all important for what we call health. But these health outcomes are often not measured in these large evaluations as sort of the last possible outcome in these evaluations. If these things are mission critical, and I had an exclamation point before, now I put a question mark, and I'll tell you in a minute why. But this is also my conflict of interest slide, because I'm an outcomes junkie, and I'm very interested in evaluating and thinking about outcomes. This is my work on PEPFAR. And the outcomes in terms of all-cause adult mortality from a previous analysis. So are the health outcomes really all that important to the large evaluations of global health initiatives? And I think the answer is yes. Why? Let me give you a few reasons why I think they're so critical. Intermediate progress may not map to health improvements, and with a lot of the discussion on theory, I think there is lots to be said still for surprises and unexpected results. And so, just to give an example, we think we know a lot about diabetes and sort of medical research. We the dogma about diabetes and how it is caused and how we treat it is almost as much dogma as gravity. We always it's always better to reduce sugar and to intensively control diabetes. Well, Just before changing the guidelines, one of the major guidelines committee said, you know what, we just need to do this trial. Just, we know that it's good. Lower is better for glucose. But let's just do the trial. And lo and behold, as compared to standard therapy, the use of intensive therapy to target normal glycated hemoglobin increased mortality. Did not significantly reduce major cardiovascular events. Okay, there are always surprises, even when we think that we understand a lot of the proximate or intermediate outcomes. So despite a lot of the concerns about hyper-empiricism, there is definitely a role for empiricism. Not discounting many of the work that goes along the way to try to understand what happens between the beginning of the intervention and the final outcomes, but the final outcomes are critical. The people want to know, and again, I added a question mark because at some point in the past day and a half, I asked somebody, why do you think mortality outcomes are not being measured sometimes in these large evaluations? And they said, if to the extent that these evaluations are about accountability, for most people, for the taxpayers, for Congress, it's enough to know that money is being spent responsibly, not necessarily that it's actually affecting mortality at the other end. But it is critical for comparative effectiveness and value, and I think we'll hear more about that from some of the other speakers. And then it's important for dealing with dragons. There are lots of people who are sort of breathing fire down the 4 and 8 community, and for better or worse, in some degree or another, a lot of what these global health initiatives and the programs are about is a form of development assistance of foreign aid, and there's lots of both theory and practice that suggests that foreign aid is potentially not necessarily a good thing, that it possibly distorts what happens in recipient countries. But in some of these discussions, especially in the health arena, the evidence still needs to be established, and that's an important. Sorry. So the two people here was the man is William Easterly and the woman is Dambisa Moyo. William Easterly has written a lot of the academic papers and books. Dambisa Moyo has written a slightly more sort of popular book called Dead Aid. She's a Zambian former Goldman Sachs consultant and now mostly an author on a lot of these issues. So what are the errors? Here's some of the answers that we've heard and I've received in this last couple of days. Context matters, and sometimes it's hard to understand. It's hard to attribute the outcomes to a very heterogeneous and complex programs. There's not enough time in the evaluation. There's not enough money. I wish we would. And sometimes the existing findings and methods maybe they're adequate. I'd welcome any others why people think that these things are rare. Where do they come from? This is just sort of as a review of some of the landscape, and then I'll go into some of the ideas where I think where health outcomes can come from. You can either have a primary data collection effort, such as what a lot of the Poverty Action Lab and the Institute for Poverty Action when they start evaluating a new program out in the field. But you can also have on a national level, such as the Mexican Seguro Popular evaluation. You can have aggregated data outcomes either from World Bank or such estimates with all of their limitations. And you can have existing microdata such as demographic surveillance sites or household surveys. With this, I'll just sort of put in one slide of glowing praise for DHS, not because our panel's chair is the director of a lot of the DHS. I do want to brown nose to Martin, but that's not why I have it here. Because DHS is truly a remarkable effort. Probably do not need too much of an overview of DHS, but it's been going on since the 1980s in a very consistent way. It's very high quality data. It's available for providing a lot of national information for the countries where it's being conducted. There are many professors in many universities in either economics or sociology or political science or medicine that have received tenure because of DHS. It's been also of great academic value. And the whole is greater than the sum of the parts. Really, there have been a lot of amazing work that has been done out of DHS, and including a lot of very important health outcomes. Whether those are deliberately measured or sometimes sort of eked out of DHS in ways that are creative. But DHS can't always be used, and has not been used in many of the evaluations that we've seen here. Partly because of timing, DHS is carried out by and large, on average, every 4 or 5 years, and sometimes because of the measurements that are mostly, or at least sort of longitudinally, about child mortality, maternal mortality, but not necessarily about specific diseases that people are interested. So moving on to possibilities and future options, can DHS be used to fill the gap? So I'll just sort of go through an example, such as the planned, let's say PEPFAR is planning an implementation of treatment as prevention for HIV. That can be an enormously expensive operation. Treatment as prevention would, just that as a portion of HIV treatment would dwarf things like the AMFM, would dwarf things like probably even be potentially more costly than the entire PMI. So there are trials, very, very costly trials ongoing to try to figure out whether this is truly effective for incidence and mortality reduction. Could DHS be used instead? If an implementation of a program is staggered over 1 to 2 years, if during this period of time you can field 3 to 4 DHS waves prior to and during the staggered implementation, and during the time measure all-cause adult mortality, HIV-related adult mortality, regional incidence rates, and viral suppression rates, you can actually do this and have a very strong design that would sort of piggyback on top of this kind of a data collection effort. When I mentioned this to somebody, when I sort of discussed it with a friend, he called it DHS on steroids, which I think is a sort of an apt name. Considering the cost of many of the trials that are ongoing, just for looking at the potential effectiveness of treatment as prevention for HIV, DHS on steroids in this kind of an effort potentially could be quite an attractive alternative option. And then there are sort of new ways of studying population health that are being promoted out there. I'll say one example, bring up one example. I wish I could say that this was my own brilliant idea, but I swiped it from a recent sort of editorial in New England Journal, where Mike Lauer, who is the head of the National Heart, Lung, and Blood Institute in NIH, discussed a new way of doing randomized trials, and that is embedding randomized trials in registries. By that, the specific registry that he's talking about is a registry of heart disease patients, and this was done in a resource-rich country. But you can imagine countries or cities or communities such as Matlab in Bangladesh and some of the DSS sites that can be expanded or done in a slightly broader scale or more representative scale that would allow really testing the implementation of large and complex programs. And you can embed the evaluation in health registries that collect routine health information. You can provide some upfront investments that could have really substantial downstream rewards. You can have this something that would be open to investigators. We can imagine that there's going to be a much a substantial growth in the number of studies that can be done with health registries. You can lower trial costs. The thought for for even in resource-rich countries is that registry trials cost about a 20th per patient. The recruitment costs for conducting a trial that can have substantial, again, cost implications, and can have a lot of sort of important new knowledge of the complex initiatives with all the limitations and the challenges. Again, sort of having this understanding of the downstream effects of these initiatives can have really important rewards. So in summary, measuring the direct health outcomes, it's important, but it is difficult. All of us have, all of the people who are involved in these evaluations are incredibly accomplished. They've all been to school for many years, and still it hasn't been done. The challenges are large, without a doubt. But doing this is possible. It requires large investments. There are new approaches that may be sort of worth exploring and promoting, and the returns to population health and learning could really be substantial. Thank you very much.
Thank you. Exactly in time, Iran. Charlotte? Before you start, Charlotte, I just want to clarify that Sunita Kishore is the current director of DHS. So.
Yeah.
Okay.
I'm just waiting for my slides to come up. But good afternoon. It's a real pleasure and privilege to have this opportunity to talk to you about the use of modelling. And what I've done is try and think about and give you some examples of its use for evaluation. I'm going to particularly focus on examples from HIV because that's the area of mathematical modelling that I work in and my team works in at the London School. But I think some of the lessons probably also apply to other infectious diseases. So I'd be interested in the Q&A to hear a bit about insights for people who are applying modelling to malaria or other areas as well. So what I want to do is to try and just give, for those of you who aren't very familiar with the concepts of modelling, what it is and what it essentially entails, where I think it can be particularly useful when we're thinking about either small or large-scale evaluations. What are the kind of questions that modelling can help you answer? And then give you some examples of that. I'm going to give a talk about mathematics, but not actually show you any equations. So you can, if anybody's worried about equations, they aren't going to appear. But at the same time, I apologise for, I know there's a few of you here who actually probably prefer to see the equations and who are very comfortable with modelling. So I'm trying to sort of walk a bit of a tightrope here. So apologies for that. But the kind of examples I want to give you are around, how we can use modelling to think about determinants of intervention impact, how generalisable impact projections may be between different epidemic settings or different sort of cultural settings, and show you an interesting example of where modelling was used to create a counterfactual to enable a sort of better estimate of intervention impact to be achieved, linked to the Avahan intervention in India. And then lastly, to conclude about what are some of the general issues and challenges when you're trying to think about or use or interpret modelling findings. So when people use the word modelling, sometimes they mean statistical modelling, sort of statistical inference. What I'm actually talking about isn't that, and actually I'm not a statistician. What we talk about in terms of infectious disease modelling is when we use systems of equations to describe how an infectious disease might spread through a particular population. And we use these mathematical equations both to describe the likelihood over time that different individuals might get infected with HIV, or get infected or other diseases, or might get infected with concurrent infections. So, for example, with HIV, we're interested in concurrent STI infections as well. And also use that model to say how does disease develop potentially over time? So how does it affect things like sort of levels of need for ART treatment or mortality rates in a population? So we're using these systems of equations to look at temporally the sort of spread of disease both over time and distribution of illness over time. This picture is what we often end up developing when we're working with programs to say, actually, how do we set up a transmission model and how do we try and reflect the transmission, the disease dynamics that are happening in population. And this is what we use as a basis then. We turn these sort of pictures into equations and program them, often use it, and program them for further analysis. So in this picture, it's one that we've used in a number of settings to think about transmission of HIV. For compartmental deterministic modelling, what we tend to do is divide a population. We put them in boxes. We might divide the population up by levels of sexual activity. In this case, we've got sort of no sexual activity, low, medium, and high. We're interested often in things like, how much commercial sex is happening in a population, who's having sex with who, what are the patterns of mobility naturally in that population, and what might be the extra movement that you might expect, for example, related to HIV mortality. There's a lot of interest and increasing application of mathematical modelling as part of intervention evaluation, because it's very useful when it's difficult for us otherwise to say, well, how has an intervention actually impacted on disease transmission? So, for example, for HIV, it's very difficult for us, without a very precise measure of incidence, to measure the impact of an HIV prevention program on HIV incidence. And so we might be able to look at trends in HIV prevalence data and say, oh, look, it's going down. But to actually come up with an estimate of, well, was that really due to the intervention? What number of actual infections might have been averted? How do we account for mobility and other factors that might influence those prevalence trends? It becomes very difficult using sort of the blunt measure of prevalence. And so what modelling can help you do is try and disentangle that and try and say, well, actually, given what we know about patterns of behaviour and how that's changed, what percentage of that reduction in prevalence might be due to the intervention? What's also very useful when we're thinking about interventions that are actually trying to impact on a dynamic infectious disease is it gives us an approach not only to try and measure, well, what is the impact of the intervention amongst the people who directly had contact with the intervention, but how might any behaviour change that's resulted from that contact translated into averting downstream chains of infection. So, for example, an infection from a sex worker to a client, to the client's wife, from the wife to the baby. And so it gives you a way of adding up that downstream chain of infection and saying, actually, this is the cumulative benefit of maybe a very focused intervention reaching quite a small number of people, but actually in terms of the epidemic in a country might have much broader benefits. It also gives you an approach to say, well, what might happen in the future? If we avert a major outbreak of an epidemic by doing an intensive intervention over 5 years, but actually the benefits might last for the next 10, 20 years. Modelling also can be used to try and help us count up the downstream benefits of current or recent actions. In our group, we often use also modelling in combination with economic evaluations, because using modelling, we can get estimates of cumulative HIV infections averted, which we can then link with costing to get estimates of cost per infection averted. We can get things like DALI estimates. We can add on STIs. We can do many things once we start to get those model projections. So to give you a sense of what is actually the process if you want to develop a model related to a particular intervention, there's quite a number of steps to it. We often get approached by different governments or UN agencies, and they say, well, have you got a model that can do this? But actually in practice, when we're doing the modelling, we're really sort of developing commonly a model that can fit well to the particular setting and epidemic realities that the program is working on. So often we'll start off drawing those sorts of pictures that I showed you with what might be the building blocks of the model. We will then formulate that into mathematics and code that model. We'll then need quite a lot of setting-specific data to say, well, to try and input in what is the distribution of sexual behaviour, for example, in that population, and what is the uncertainty around those inputs. Modellers are getting quite sophisticated about, actually, we don't always believe many of the data that we have from surveys, for example, on reported condom use. So when you're factoring in the modelling, it's not only what does the survey data say, for example, but also how much uncertainty, how much do we believe that, what might be the uncertainty abounds around some of our key inputs that we want to make sure we're reflecting in our subsequent impact projections. What we do then is we sample across those uncertainty bounds to get a number of different combinations of potential model inputs, which we then run through our mathematical model. And then we use setting-specific epidemiological data, say on HIV prevalence, to say, well, which of those combinations of inputs actually fit to the real HIV prevalence data that we have. So this plot on the right shows, for example, data fits to Gauteng HIV data in South Africa. So the red line on the top is the sort of projected prevalence over time amongst females, and the one on the bottom is amongst males. There's a couple of data points to the right, I don't know if you can see them, which reflect the actual data and the uncertainty around the HIV prevalence data from that setting. And then those shaded bars around those lines give you a sense of all the model runs that actually fit within that uncertainty. So then when we're going on to make impact projections, we're incorporating that whole bound of ranges of model runs that could explain the epidemic that's being measured in that setting, and using that in our downstream impact projections. So once we've got those fits, what we then do is make comparisons and say, well, what do we think would happen in terms of the epidemic given an intervention? And then we try and say, well, what might have happened without the intervention? If we've got a randomized controlled trial, we use the control population data for the without setting, or in other cases we might have to extrapolate or develop some sort of counterfactual argument to say what might be the assumptions about behavior if there was no intervention. And from that we use the modeling to obtain projections of intervention impact and the associated uncertainty. What's very powerful about mathematics is very technical, and it can be a somewhat complex thing to set up, but actually I think it's something that could be very useful at a whole range of stages of program evaluation. So at the formative and early stage of planning, for example, you can use modeling to say, well, what might be the impact of a particular intervention if we added this new test into our health systems, if we scaled up pre-exposure HIV prophylaxis, for example, that's the thing that everybody's modeling at the moment. If we had a female-controlled microbicide, what might be the impact of introducing these technologies? Is this something that's worth pursuing? But also you can use it to say, well, what might be core elements of an intervention that we really want to get right because it might be central to determining impact? And the thing that sort of somewhat amazes me when I look at global agendas and targets is there'll be targets of reducing HIV by 20% or 15% or whatever, or eliminating HIV, but without really going through and saying, well, what might that really mean? What does that mean in terms of the intensity of program coverage or the effectiveness of the intervention components that we need to actually reach those global goals? And that's what modeling can help you think through in quite sophisticated ways. Similarly, when you're thinking about a stage maybe of doing small-scale delivery of programs, so you're starting to get real data about an intervention's effectiveness, and you want to think about, well, what might be other settings where this might be an effective intervention. Similarly, you can use modeling to say, well, what if we translate this intervention to a different epidemic setting? Would we see similar impacts, or how would impacts be influenced? And you can also use modeling to tweak things and say, well, how could we potentially optimize impact in the future refinements of the intervention? And lastly, when you think about large-scale programs, you can use modeling to think about the widespread intervention impact and cost effectiveness. Okay, so moving on, I want to talk through 3 examples, one from each of those 3 blocks of sort of applications of modeling. So the first one is from that sort of early stage thinking about program delivery and planning. And this is work we did thinking about future introduction of microbicides. And we got quite interested in, well, everybody's sort of interested in how good is the product, but actually we're interested in how quickly can you get it out and how widely can you make that product available, and how might those realities of your strategies about product introduction influence your downstream impact on HIV incidence. So this was a sort of a hypothetical kind of trajectory of the way you might think about product introduction in a particular setting, that you've always got delays at the beginning. There might be a period where a product is restricted, then it might move on to more, less restricted uptake, and you'll reach some level of saturation. And then what we did is, for different scenarios about how the strategies and how successful you could be at getting a product out into a particular population, model how that might translate into impacts on HIV incidence. So what this plot shows is, so along the top row, you've got different scenarios, those different uptake curves that I showed you. The first one is you get things going pretty quickly. You scale up quickly, you get up to a 60% coverage in sort of five or so years. And on the bottom, I've got a plot of the associated reduction in HIV incidence. So the higher the bar is, the better your impact is. So if you do everything's really well, yeah, you get a pretty good impact. And then we just played around with, well, what if we had a lower coverage? Your incidence was reduced. If you have small delays in delivery, that's the sort of bars in the middle, the examples in the middle, it pulls your incidence down a little bit, but not so much. But if your coverage it isn't that high, so in this case it's something like 20% after 10, 15 years, actually your impact on incidence is far, far lower. And this is in some ways probably showing the obvious, but actually in terms of policy discussions about what do we really need to focus on when we're delivering or introducing a new technology, to use modelling to help develop targets and think through what's the scale that we need to achieve to actually have impact, it can be very, very useful. The second example is from work that we did to try and think about, well, to what degree might findings from intervention evaluations translate to different epidemic settings. And in this case, what we modelled is the impact of a condom promotion intervention in both Hillbrow in South Africa and also in Cotonou in Benin. So very different HIV epidemic settings. In Cotonou, the epidemic is much more concentrated amongst vulnerable groups. In South Africa, far more generalised, extremely generalised. And in this case, what we saw was actually in terms of percentage decrease in HIV incidence, for the same intervention, very different projections about reductions in HIV incidence. And actually, what surprised me and why I'm showing this, even though it's a few years old, is because actually in the more concentrated epidemic, we had greater projections of reduction in incidence, whilst in South Africa, we had smaller projections around impact on incidence. And that's really because in South Africa, you have a greater underlying risk of infection. And so actually it's much harder to knock down the epidemic in terms of reductions in incidence. Because incidence is so high in that setting, you can avert a high number of infections. So actually if I showed you a plot of cumulative number of infections averted, it would be higher in South Africa than in Benin, but in terms of impact on incidence, it's the other way around. So again, sort of modelling can be quite interesting and useful that way. And then the third example is around the use of modelling to create counterfactuals. And this is a really nice paper that came out in the Lancet mid last year, which really is a culmination of many years of modelling done by Imperial College and the London School with the Avahan initiative, which used detailed data on behaviour and on HIV prevalence to make projections of the impact of the Avahan initiative across southern India. And this plot shows you the way that, a little bit, it gives you a flavour of the way that they did this. So on the left, this plot shows the assumptions that were used and the projections made in the modelling about levels of consistent condom use amongst sex workers. So the red bar is showing you what are the trends that came from the data collected over the intervention and the associated uncertainty. And then the blue line shows the assumptions they made as a counterfactual. So what if, and so in this case it's assuming that condom use, where the intervention started, that condom use continued to increase and then plateaued at a lower level than with the Avahan intervention. And then on the right is the corresponding plot then about the projections of what would happen in terms of HIV prevalence amongst sex workers, both with the intervention and if you hadn't had the intervention, so if using the counterfactual figures. And then what they did is use that and modelling by district the impact of the Avahan intervention produced estimates of the cumulative number of HIV infections averted by district. The plot on the left shows estimates of infections averted over 4 years, and the plot on the right over 10 years. And this projection gives you estimates not only amongst the impact amongst sex workers, but the downstream chain of infections, so what I was mentioning before. So how by averting infections amongst sex workers and the clients, you also avert infections amongst the partners of clients and the broader population in those settings. So in conclusion, I hope I've given you a flavour of some of the ways that you can use modelling and a sort of feel of how powerful it can be. When we actually look at current applications of modelling, I see it used in a couple of different ways. I see a lot of modelling that is used for advocacy, essentially, as well as a rigorous evaluation. And it's a very complex technique, so sometimes as a modeler, when you're reading papers, you know, I might be critical of something. There's it's a slightly black box process, and we're only as a field really starting to kind of have guidelines about what to include in write-ups of modelling projections. You know, what are the underlying assumptions and building blocks that have been used to create projections? It's very powerful. It can be used to produce big numbers. The picture from The Economist is coming from modelling projections about the impact of widespread treatment. You know, widespread treatment has huge impact, it's incredibly potentially important, but if that you can come up with statements that we can eliminate HIV or avert 5 million infections, that's the sort of power that modelling can have, and of course that can be used and abused. In practice, I think modelling is dependent on good data and strong collaborations with programs. We could be using modelling far more than we are currently, both to inform the design and planning of programs as well as for evaluation. And really the most effective way of bringing in mathematicians as part of the multidisciplinary evaluation team is when mathematicians are brought in at the outset and the required data for modelling is collected as part of an evaluation strategy. Thanks.
Thank you. Thank you very much. Rachel Nugent, our next presenter.
I think I feel much like Eran feels. So I'm bringing some notes because I don't trust myself to remember what I need to say. So having come a little bit far yesterday, I'm just starting to wake up. But thank you very much to the Planning Committee for inviting me here today and yesterday. I'm really delighted because I have learned a lot. So I hope I have a little bit of useful stuff to share as well. And I think this is a very nice fit following Charlotte's presentation because what we're doing is taking epidemiological mathematical modeling and adding on some economic features, or taking cost effectiveness analysis and adding on some additional economic features to try to build out the array of results that might be available and useful to policy decision makers. And we're also aiming to answer some of these what-if questions. So I guess in the interest of truth in advertising, we are not really applying quantitative methods for evaluation on a large scale, at least not as we've talked about it here at this workshop. But we are doing a very large-scale project called DCP3, and we're developing quantitative methods to apply across many pieces of DCP3 and modifying existing methods to try to better inform priority setting. So let me explain a bit. Oops, I wasn't supposed to do that. But that'll... There, okay. Very briefly, a bit of background about who we are and why we're doing this. DCPN, Disease Control Priorities Network, is a 7-year project funded by the Bill and Melinda Gates Foundation and implemented at the University of Washington by the Department of Global Health and the Institute for Health Metrics and Evaluation. The PIs are Dean Jamieson and Chris Murray. And DCP3 is the main product of the Dean Jamieson half of DCPN, which is housed at the Department of Global Health at UW. And these are our objectives for DCP3, and the work I'm discussing here emerges from the third objective, the advancing knowledge and practice of analytical methods for economic evaluation of health intervention. So evaluation is a part of this in the sense that we're doing broadly economic evaluation and advancing some methods on it, but not for the purpose of evaluating a multi-site project or something of that nature precisely. So what I'm going to talk about, a little bit of background first. The starting premise for us is that health decision makers are making choices in a complex environment with limited information. We all know that. We're all trying to use synthesize, evaluate, provide information to try to improve that information environment. And we think that we economists have something to offer, but we could do a whole lot better than what we are doing in providing useful information. So to use, I think, John Simon's metaphor yesterday, which he used before I got here, but I think I picked up on it, the standard economic hammer, of course, is the cost effectiveness analysis measure. And there are many well-known criticisms, well-justified criticisms, which I don't need to recount for this audience. But one of them simply is that CEA doesn't provide sufficient information about the kinds of sufficient information of the type that health ministries and other decision makers need. It's often too narrow about a given intervention. And nowadays, I think it's more and more obvious that decision makers are looking at combinations, whether it's packages or whether it's a delivery platform or public financing of an array of things. So we need to broaden the results of the economic evaluation that we're doing to give them some better guidance about the economic results or implications of their choices. And that's essentially what we're trying to do. We're finding kind of, in terms of the standard economic toolbox, we're trying to find this middle ground between cost effectiveness analysis and cost benefit analysis, which has some fairly significant data and measurement issues around valuation and so on. So in a way, we are trying to drive down the middle and develop a dashboard of economic outcomes that can be compared across a broad range of intervention choices, but more than just single interventions, more complex choices, if you will, of policies, packages, et cetera, as I was mentioning. So one goal would be to try to inform decisions on UHC, which are much discussed and implemented these days. And the economic outcomes that we are trying to add to the sort of evidence base primarily revolve around equity and financial risk protection. So that's what I'm going to focus on here and talk a little bit about different definitions of those things that are out there in the literature, and then give you an example of one of the analyses that we've done, which has to do with HPV screening. HPV vaccination, put screening in the wrong place, cervical cancer screening and treatment in China. To help motivate why we're doing this, we can look at some global health milestones. DCP1 and DCP2, which most people here are familiar with, were, I think, hugely instrumental in advancing understanding of the economic aspects of health and what economic information is useful to inform health decisions. The World Health Report 2000 was also a very seminal document for a number of reasons, not least because it began to expose how poorly the U.S. health system was doing on a comparative basis, but also because it asserted that health systems are supposed to provide more than just health. Yes, health systems should provide improved health outcomes, but they should also provide economic outcomes, that is, not impoverishing people or preventing the impoverishment of people for medical reasons, and providing some fairness in people's ability to get health and be healthy. More recently than the 2000 report, of course, more recent WHRs have talked about universal health coverage, and as I said, much discussion about what should be included. What will it buy when countries implement UHC? What are the kind of trade-offs that might be faced? And so I think that's a good motivator for what we're doing. I think we're trying to help address some of those questions. And a reasonable set of goals for a UHC program would be to figure out how to design a basic insurance package or some level beyond basic if it's affordable, taking into account burden in the country, costs, equity, and the financial risk protection or avoidance of medical impoverishment. And so that's what we hope to help inform, among other things. So a few definitional features, and in the interest of trying to adhere to the guidelines set by the organizers, I'm not going to show you lots of graphs of data, but we can come back to some of these kinds of things. But just an example on measures of equity. So we need to be able to to measure these different economic outcomes that we're interested in. This is meant to be illustrative. There are different ways of measuring equity, if you will, a lot of different measures, different definitions of equity. Here's an input type measure and an output type measure. Fairness in the distribution of coverage, fairness in the distribution of health outcomes. There are certainly others. Looking at medical impoverishment or the question of financial risk protection, I'll spend a little bit more time on this one, but again, there are many things we could come back to. We all know that in both rich and poor countries alike, that people, when confronted with medical expenditures, often face out-of-pocket expenditures. If they don't have adequate financial protection, it can be impoverishing. It isn't always, of course, but we want to be able to measure that. Who is affected, how are they affected, to what degree, et cetera, and what can health resource allocation decisions do to prevent that medical impoverishment. So there are a number of literatures around all of this. The threshold-based approaches, Adam Wagstaff and many others have written about and taught about for years, the measure of catastrophic health expenditures at a certain percentage of disposable income, 30%, 40%, 10%. It varies, across different usages, but there's a lot of literature on that. What that does to create or avert poverty if you protect people from those OOP payments. Margaret Crook and others have done work on medically related asset selling and borrowing, measuring that in different countries. That's another way of measuring people's exposure to medical impoverishment. And then maybe a less well-known literature that a number of economists and ethicists have worked on, the money metric value of insurance. McClellan and Skinner, Peter Smith, Amy Finkelstein, and others, and we have a paper published on that as well, Virgay, Laxminarayan, and Jameson, trying to measure a risk premium. That is, put simply, what is the premium that people are willing to pay, the value of that premium to them of being protected from the medical impoverishment. So our work is actually using all of these approaches or choosing among these approaches and then comparing them, these approaches in the sense of different definitions, and involves some different measures. And of course, financial risk protection is offered with a number of programs in a number of countries, and some of these have been evaluated. There's continuing work on trying to provide financial risk protection through different systems like Mexico Seguro Popular, and evaluate those. But there's definitely, as Margaret and I were talking about last night, a need for more evaluation of these financial risk protection efforts. Some of them, such as Medicare in the US, that seem to have worked very well. Other parts of US programs not so well, as we're learning. So let me get more specific now. That's a background and the motivation for us. So we have moved from CEA to what we call extended cost effectiveness analysis in the work that we're doing, ECEA. So very simply, what we're doing is trying to bring more richness into the modeling to be able to give a story about distributional consequences, equity, if you'll allow, and financial risk protection benefits to individuals. And we can, individuals and households, and we can, depending on the data, tell a different story about who's affected. That is the incidence of the risk protection benefits. And just to underscore a point, I guess, in terms of why we're doing this, just because something's cost effective, of course, doesn't mean that it will have the desired distributional goals, or that it will prevent medical impoverishment. So cost effectiveness, is a big part of what we're starting from, but our work is suggesting that it's simply not sufficient to answer the kinds of questions that are being asked by decision makers. So I guess to, again, try to set it in the context of what we're doing here, we're trying to achieve some of the goals of evaluation, producing multiple measurable results, such as what Erin was asking for, with a fairly simple approach that doesn't require complex multi-level modeling. We're not doing that here, but that does allow us to contextualize for different country conditions and policy choices. And that's sort of again, that driving down that middle ground is what we're trying to do here. So the example I'm going to talk about briefly is this HPV vaccination policy in China. And you have to look at the vaccination and then cervical cancer screening and treatment all together, because if you just look at one of them, you're going to miss a lot of the important impacts. They have to go together to really be able to talk about how what you get out of a policy of HPV vaccination. So let me walk you through our black box, if you will. It's not really very black because it's pretty transparent and fairly straightforward. In this study, we started with and this was led by, I'll give names at the end, Carol Levin at the UW, Manisha Sharma, based on some work of Sue Goldie and Carol Levin, CEA work that they had done in the past in China. So the initial starting point is the policy of government-paid HPV vaccine. So our health policy lever in this case is the vaccine program. Then we have a range of expected impacts here, and I hope you can read it, where I guess the monitors are all over the place. We would expect health gains measured by cancer deaths averted. We would expect some change in household expenditure measured by treatment expenses averted. And we would expect some financial risk protection benefits measured in terms of the importance of those averted treatment expenditures in terms of the household budget, or in terms of the household income level. And in the lowest row there, you can see that what we've done is to measure all those effects by income quintile. So in this case, that's our sort of distributional measure, but we could use rural-urban. If it's a policy that is relevant to men and women, we could look at males and females and see if it's more pro-male, pro-female, et cetera. So there are different ways we could disaggregate the population if we have the data to measure different distributional aspects. So this is a really kind of nasty slide here. It's not all that complicated. I'm going to walk you through the results here very quickly, and then I'll wrap up. A bit of background first. HPV is not on the immunization schedule in China. So far, the vaccines made by Merck and GSK are not registered in China, so the cost of it, if somebody wanted to buy it out of pocket, is very expensive, about $100 per girl to vaccinate. China is developing a vaccine, but it's still a few years away. So the assumption here, sort of the background assumption, is that China would, if they decided to put HPV on the schedule, they would negotiate a price with GSK Merck, such as PAHO did, for instance, say $13 per girl, which is what PAHO got. So that's just an assumption, a starting point. And the policy we're evaluating, as I said, is to introduce the vaccine and have it wholly or partially paid for by the government. So in the top row here, we're looking at deaths averted per million women. What we did, we have a cohort of 5 million girls. It's a birth cohort of 5 million girls. We're putting the cohort through the model. 1 million girls per income quintile. So those are all even numbers of girls. And you would expect the numbers of deaths averted to be the same across all the income quintiles, except that the current screening for cervical cancer is not the same across income quintiles. So the screening rate that exists right now ranges from 5% for poor rural girls to up to about 30% for non-poor urban girls. Quite different. China's been trying to establish universal screening for a while. It's not working all that well, but it does vary, and that's important. So that's why you see a lower number of deaths averted in the higher income quintile, because they're being screened and they're already averting some deaths there. Another thing to mention is that this is just a one-year model. It's not a multi-year model, which makes it much, much simpler for us, but of course is sort of it is illustrative. It's not going to tell us everything that you would want to know. Going to the next row, government cost per million women. This is a fully loaded government cost, assuming they would negotiate a reasonable price, and assuming that you would reach 70% of China's 10-year-old girls. And there are about 6.5 million 10-year-old girls in China. So the total cost of covering the population of girls with this vaccine is only a couple of $100 million a year, less than 0.5% of 2011 health spending. So in the paper, there's much more detail about all of this, but it's a relatively cheap vaccine relative to what China is spending on health. So that's the government cost. Next row, the government cost per death averted. That's a simple calculation. We've seen deaths averted, we've seen the government cost. And again, because you've got greater screening already in the higher income quintile, so you're averting some deaths, you have a lower government cost per death averted in the higher income quintile, but not big differences here. Okay. Just to sort of get to the main points here, treatment-seeking cases of cancer averted. You're, again, averting fewer cancers in the higher income group. Therefore, they don't need to be treated. Therefore, fewer people paying for treatment in that group. There are more cancer cases in the lower income quintile. And that's sort of just reinforcing what I've already said. There are more cancer cases that happen in the lower income quintile. When you look at the patient cost savings, patients are paying out of pocket for cancer treatment, and there are differences in the treatment that low-income women are accessing versus high-income women. Low-income women accessing much cheaper, less extensive treatment. So there's cost savings across each income quintile, but much more cost savings to be had by the richer people who are paying much more out of pocket. And then just to sort of wrap up, looking at the savings to the households as a percentage of their income, you can see, of course, that is a greater number at the low income levels. That is, their savings are a bigger, more important in terms of their household income. It's a bigger part of their budget because they have a lower income. And then cancer reduction is basically the same because there's no biological reason to think that it's different across SES categories. So this is the almost the last slide, just a nicer way of presenting a couple of these pieces of data. One, that you have savings as a percentage of income in the red line there. That is, the savings from the policy to the lower income people is a much higher percentage of their income. So you could call it a pro-poor policy. And the patient cost savings in absolute terms in the black line, going up pretty significant numbers in total absolute amount. So I'm going to skip this in the interest of time because I have run out of time.
Wrap up.
Okay. We can come back to this, but essentially what we're trying to do is figure out where different policies, packages, interventions would lead us in this. This is actually just two-dimensional. We've added another dimension of distributional effects, and I can't do a three-dimensional graph. But do we end up in the very, very nice place in the upper right-hand corner of high health gains, high financial risk protection, and then whatever distributional consequences we would like to get? Or do we end up in a much less desirable place where we're buying lower health gains, lower financial risk protection, not the right distributional consequences, or somewhere in between? And we have a number of studies we've done and different examples that fall into this matrix in different places, which we can talk about in the Q&A. Simply to say, you know, I think most of us would agree that comparable quantitative measures can be very powerful for policy purposes. There's a lot of tension between a complex contextualized model and a more generalized analysis, and we have chosen a more contextualized model. We have worked with an agent-based model as well as this more simplified version that I've presented here, and there are important trade-offs there. It's very difficult to get the data that you need broadly across the range of health topics and levels of health systems and population characteristics for any given country. So we had originally planned to have several representative countries that we would focus on to do a broad range, and what we've had to do is more opportunistically work in a number of countries because it's really important to work with people who know the health systems, the populations, the data, et cetera, and that's what we're doing, collaborating with people in country on most of the studies we're doing.
Thank you.
So that's it. Thank you.
Okay, thank you all the presenters. We had three quite different presentations. I guess the first two, Aaron coming up with a couple of potential methodologies to get at health outcomes, and an impassioned and detailed review of all the benefits of modeling. and then the latest one on comparative cost effectiveness. So I open the floor to questions. Hold on.
Thanks for this. I have Ruth Levine Hewlett Foundation. I have a question for each of you, actually. So I'll do it in order. So Aaron, you know, one of the things that's very interesting to me is how demographic surveillance sites can be better used for intervention research. So you mentioned it, maybe 2 sentences. I'm wondering if you could expand a little bit on that. Charlotte, so I was involved in an early discussion with the Avahan program about what kind of evaluation framework could be put in place. And I will say my recommendations were not taken up. So it would be interesting to me, at least, to hear from your perspective, having worked on a kind of model-based evaluation, or at least introduce that modeling into evaluation work of Avahan, whether, if at all, introducing a kind of randomized rollout of that program would have generated data that would have been useful for evaluation. And then for you, Rachel, thinking about the tools that you're working with, can you talk a little bit about how they might be used in the context of a program evaluation? So, for example, for the President's Malaria Initiative or for Gavi, is there a way that this look at distributional impacts could be applied in a useful way?
Okay. Maybe we should take these 3 questions and give people a chance to come up with others later. Eran?
Sure, that's a great question. So just as a brief background for other people, so DSS, the demographic surveillance sites, there's a bunch of them, but they're essentially a relatively small or constrained community where you can get very high frequency, very high quality data that gives you a sense of what's happening with respect to sort of demographic changes, births and deaths, and causes of deaths often. Part of the challenge with using them for broader impact evaluation is that they're constrained. Sometimes it's a single site or a single town, and so generalizing from that it can often be challenging. That said, there are lots of examples where those sites have been used, really to great effect. And the most, probably the biggest example is MATLAB in Bangladesh. It's been used for demonstrating that. Oral rehydration salt, and many other interventions have been are extraordinarily effective. For policy, the challenge is sometimes is that the policy is implemented, or for a large program, it's implemented either at a regional level or at a country level, and so it needs to be thought of as a little bit broader. I can imagine a situation, sort of just one possibility, where, for example, in Kenya, you currently have 2 or 3 DSS sites. Expanding that to 5, 6, 7, 8 would then enable you really to sort of evaluate changes sort of with attention to the context and have a broader generalizability for what the policy impact or implementation would look like. Again, I'm sure there are sort of other creative uses of such data, but again, sort of building up on high frequency, high quality data can have very large implications.
Charlotte, comment on Avahan?
Yeah. I think that I know there was, there's been this ongoing discussion about, the sort of Avahan intervention, and would it have been possible to do a sort of large cluster randomized controlled trial, essentially by randomizing the scale up of the intervention. I think when you're thinking about doing evaluation, it's always that trade-off between the political realities and what's feasible and what's ideal, and so I think that's what, my understanding of what the trade-offs were happening on the ground, and to actually do that scale of targeted interventions with highly marginalized populations across all of southern India, to then try and add on an element of actually delaying intervention delivery in some sites and so on. To me,
well, let's just do a thought experiment. What if, just relax all those concerns, what if it had been possible?
Again, I suppose, I mean, Gina's sitting here, so I want to get, we should have a three-way discussion, but for me, I like the way they did it, personally, because, we had a lot of evidence that sex worker interventions, fundamentally giving condoms to women having lots of sex, really helps curb the epidemic. There was an epidemic that was on the cusp of taking off across southern India, and so I think the political decision was we try and do that at scale, we try and develop and support systems to do that at scale, and then do rigorous evaluation alongside that, versus saying we want to use this to create the strongest, to generate the strongest evidence we can, but that inherently means delaying intervention delivery in some sites. So personally, I would go the way that they did, and actually what I've learned a lot from, sort of seeing the intervention and being involved in some of the analysis and costing of the studies, actually the way that the data collection fed into program delivery, that symbiotic relationship is really the way I think that evaluation research should be going. That the pure randomized controlled trial is our ideal, but when we're thinking about large-scale delivery, I think it's how can we make the rigors of the scientific method work in combination with large-scale effective program delivery. How do we achieve those synergies and also do good science along the way so that actually we can come up with useful examples? And so to me, Avahan gives us a really interesting example of that.
Very good. Rachel, comment on how the tools may be used for evaluation?
Sure, you might come back, Ruth, on that. But in the meantime, Gina, that's a softball question because obviously in the context of this workshop, I gave some thought to how relevant is what we're doing to these big kinds of evaluations. And I think that the big multi-country program evaluations it's not what we designed or what we're really intentionally developing this for. However, I think that it can present a fantastic opportunity to collect the kinds of data that are very hard to find out there in a comparable way. There's no reason in the world that it would be hard, I think, for a Gavi or a PMI or even a PEPFAR program to be collecting some of the key data that we need to be able to produce these economic outcomes. And I guess if people accept that this additional array of economic results is useful in the policy decision process, then I would urge these kinds of larger evaluations to think about doing that. So it's not only data collection, but I think doing that data collection, the analysis that we are doing isn't very complicated, frankly. It could be much more complicated. It should be more complicated, and I think will be going forward in terms of being able to accommodate sort of multiple combination interventions, packages especially, which we haven't really gotten into, to be perfectly honest, yet. But I think that it's feasible. There, one of the rate limiting things is just, what epi modeling is available or can be done that involves combination interventions. And there's not a lot out there even in the CEA world. But it really isn't that hard to go from the CEA world to the UCEA world. And if you can get better data on costs and household effects, then you can do it. So I would say it's a good opportunity if the will is there.
We'll take 4 questions to start off with. Kara, and then... Oh.
Okay. Maybe Gina.
Yeah, go ahead, and then Kara, and then back.
Okay. No, because Gina wanted
you
to
want
say
to follow
something
up?
on the...
Go ahead, please.
Because my question will probably follow up on that.
Yeah,
Maybe she may give the answer already.
Strategic ordering.
Yeah, thanks, Charlotte. I just wanted to add that I think that we felt that giving condoms to sex workers didn't need to be tested as an HIV prevention strategy. So we didn't need to phase in to prove that it worked. It was a known solution. So, but that being said, there were many things that I think we could have done better in the evaluation. So we didn't have a baseline. I think we probably couldn't have done a baseline in the classic sense. The baseline took us 2 years to do. I don't know that I would have withheld condoms from sex workers for 2 years to mount the baseline. We could have shortened the baseline a little bit, but we had to involve the government, and that took a lot of negotiation. But we could have had program data better collected to get a baseline, which we didn't do, and that was one mistake. The second is we couldn't use government as controls because we wanted to transition to government, and politically we couldn't do that. So we couldn't use that as control. We could have looked at the new element in the Avahan that was a little bit different was community mobilization, which was really a new element. We could have tested that more rigorously if we had thought about it. That we could have randomized across the program. That would have been something we could have tested more rigorously, and we didn't think about that. But I think giving condoms to sex workers, that wasn't something that we felt needed to be tested. There was enough empiric evidence that we didn't need to withhold that intervention from anyone to prove that. So.
I mean, yeah, just to add, I mean, I think the cumulative, the question, to me, the evaluation question was more, can you do this at scale? And when you do it at scale, does it impact on population prevalence?
Okay. Sorry, Kara was first, and then, you have that.
No,
mic.
it's just because it's on the same.
It's on
notes,
the same thing?
So
Go ahead. Go ahead.
It's just to follow up on this whole discussion. What you're saying about modeling, and I'm also familiar with the Avahan program in different ways. The use of modeling to create counterfactuals, I think, is one of the very attractive new things that models can do, especially to actually provide an alternative for the whole, if you don't randomize for whatever reason, you don't do it. But it's I don't know how new this is. For me, this was new, but maybe this is something that has been used already in the past more. I don't know how much experience. I just wanted to get a feel from you. Is this something, is this an evolving field? And if you would give advice to other program evaluators, what is kind of like the minimum information or data that you need before you can really do this in a bit of a meaningful way? Because, I mean, you can probably always try to model something, but to do it in such a way that it comes, that you can say with reasonable confidence that this is, because I have the impression maybe it's that with complex interventions, that's going to be one of the ways to go, because you're not going to, in many ways, there's no way you can randomize, or you don't want to randomize, or you think it's not even appropriate to randomize for whatever. So if you want to have some level of comparison and a counterfactual, it seems like we put all our hopes on the modelers now. So I just want to have a bit of feedback from you where we are with that, and what is the minimal requirement in terms of data to be collected.
Yeah. Let us ask 2 more questions before we answer. Kara?
You should say your name and where you're from.
Oh, okay, sorry. I'm Marie Laga from Institute of Tropical Medicine in Belgium.
So I just wanted to really pick up on Ruth's question and to see if we could advance that argument a bit more about how important is it in looking at global health initiatives to look at value for money and at cost effectiveness, and think through some of the methodological challenges of doing that, because more often than not, there aren't very good comparators around, because by definition they're at scale, and so you end up being, certainly with AMFM, we sort of looked at it, so what could you compare in terms of cost effectiveness? Because most of the other previous subsidized drug programs operate at really a very small scale, and I think that is information that's increasingly being demanded by decision makers and international donors, saying, well, why should we do this rather than that? But I think that when looking at these large scale initiatives, we really need to reflect on how to produce information that will help make those decisions.
Another question?
Callum Davey from London School of Hygiene. There's really interesting presentation. So I was just wondering if you could maybe reflect a little bit on these issues around sort of objectivity and independence and so on that we've heard quite a bit about in the last couple of days. I think there's sort of been a lot of talk about like institutional separation and so on between evaluators and implementers, but this discussion around the use of routine data and so on kind of starts to raise ideas about, well, what happens if the evaluator is actually in control of the intervention, for example, with a randomized step or or whatever, but the data itself is independent of that person and the analysis is done. I was just wondering maybe a bit of reflection on how you see, and certainly the modelling side, you know, there's a big conversation that has to happen between the evaluators and the implementers to make sure all the right stuff is being, all the right data is being collected and so on, and the modelers have a full understanding of what's intended with the intervention. I was wondering if you could maybe just reflect a little bit on how you saw that objectivity coming through in these more sort of overlapping and complicated evaluations.
Okay, let's go in sequence here. I think Charlotte, if you can ask, talk to Anne-Marie, and also bear in mind Davy's comment as your last part of that
Yeah, I
your
mean,
answer.
in terms of the issue of counterfactual, we've been doing it forever, right? So, I mean, you know, in terms of modelling, when we're saying what is the impact of an intervention, we always have to have a counterfactual parameter set that we put in. I think what's happening over time is that we're becoming more sophisticated, and actually that is becoming, you know, more of a transparent process. And so what I really liked about Mike's paper and the work on Avahan is that actually, because explicitly they didn't have baseline data, they had to spend a lot of time thinking about that, coming up with a conservative estimate, a less conservative estimate, being very transparent. Well, I think in the past it's been happening, you know, it's just your baseline data or something like that. You know, if you've just got a before or after study and you're modelling that, for example, or you is at times I think being done very, very crudely, and people haven't focused in on that so much. It's like when you're thinking about, you know, case control studies and interpreting, you've got to think about how good is the control. That's not always happened when people have been critiquing modelling projections and saying, actually, what is your counterfactual? How valid is that counterfactual? And so what I see with the Avahan modelling and some of the other large-scale applications of modelling is actually that sort of mathematicians are coming to looking at that issue much more carefully and actually doing much more sophisticated analysis of the sort of behavioural data and the epidemiological data before they stick things in the model. While previously sometimes that step has been quite quick because you've got sort of modelers versus statisticians looking at the data. So I think it's something that's going to evolve over time, and particularly, like you say, with the sort of realities where we're looking at sort of combination complex programs, and so those sorts of efforts of how do we start to deconstruct different elements becomes increasingly important. We on the community mobilization piece, we've just done a pathway analysis using the Avahan data from Karnataka to try and understand, well, you know, based on the sort of a hypothesis about the pathways and the role of community mobilization, how much has that contributed to uptake of services and condom use and so on, and then put that into modelling to say actually what's the incremental benefit of that piece and linked it with cost to say, you know, incremental cost effectiveness. But the more you were thinking about those questions when we designed the questionnaires and we designed the data collection tools, you know, the better we'll be able to actually unpick those elements down the line.
Can you say a word on the independence question?
Yeah, I mean, I think from modelling, you know, the point you were making about making sure that actually modelers understand the program and the questions, that's to me the major challenge. And the sort of way that models are set up, they're quite crude. We put people in boxes, you know, so actually thinking about how, you know, you have trade-offs of complexity and simplicity. The reality of the, you know, networks of sexual behaviour are incredibly complicated. We're trying to synthesize it down to something that's much simpler, because if we try and put in all the complexity, we don't have the data. So there's a lot of trade-offs going on. So the more that there's a partnership, you know, the better you'll get. But then, you know, you could accuse the modeler of saying, "Oh, well, are you actually being objective?" For me, I think the key issue is around transparency and how do we make the process of mathematical modelling more transparent. What are some of the minimum requirements of what we want actually articulated in the main body of a paper around the mathematical modelling, so that, you know, it is open to questioning and to review. And at the moment, that's the World Bank have just sort of put out some recommendations on that, but it's sort of at early stages. But I think that's what is the next step that needs to happen.
Thank you. And Rachel, can you comment on Kara's question on the importance of the value of money?
No, I don't think I can. The context of what we're doing, really.
Anybody else?
Yeah, I'll just say a couple of things. One is, you know, the Center for Global Development has done a value for money, you know, big report on the Global Fund, and a lot of it is sort of focused on the process of getting to the point where things get to the country. But I think there is also a discussion, as a little bit you referred to it, about are things being done efficiently? And there are a couple of comparisons that you can imagine. One is comparison over time, and PEPFAR has been good about trying to sort of see how it's doing over time. And the second thing is, there are very different models of how, let's say, PEPFAR versus the Global Fund is doing HIV or PMI versus the Global Fund for Malaria, and some of those have pretty important efficiency implications. And I think those, as you're sort of again, that it dovetails very nicely with the whole notion of evaluations. If you can have a good sense of really what kind of health impact you're having, you can really have a better sense of where the potential efficiency gains can be. On the issue of independence, there's one more point that I would like to make, and I think that we've there has been a lot to do about the independence issue here, and I think there's it's an important issue. It's sort of some of it sort of implies in the air that maybe is there a concern, something about potential conflict of interest, because even if the evaluators are independent from the evaluand now, well, the evaluators, if they would want to have some kind of evaluation in the future, and so there's always some kind of how do you do the evaluation? What kind of an answer might have some implications for future? And I think having open data, having data that's sort of freely available, again, sort of would invite other people to come and use and do independent evaluations, do replications of evaluations. I think all of that is only going to be good for enhancing the validity and the trust in these kinds of findings.
Any other questions?
Martin.
Yes, Rachel?
Maybe while we wait for a question, I'll comment. I didn't mean to be glib or ignore Kara's question. Value for money is a good thing. But I think I would say, our whole project is, in a sense, about trying to achieve value for money in health resource allocations. I think, though, that the work that I presented here is an effort to think more broadly than value for money might imply. And it can mean different things to different people, so I don't mean to dismiss it at all. It's just that there are many things that we are trying to achieve, trying to get out of our health systems. And efficiency is one of them, and there are different ways of measuring efficiency, but there are other things as well. And I think to be able to look at the effect on households is really important, not just health.
I think that cost effectiveness and value for money are not synonymous, because value for money has a whole lot of other stuff embedded in it as well. But I really like the way that the extended framework allows you to look at distributional consequences. And one of the reasons for that is I think that cost effectiveness is often abstracted from the delivery system. And although an intervention in isolation can have the same effect, the way it's delivered often achieves very different distributional outcomes. And I think being able to compare the way that a given initiative delivers, ART or PMCTC or bed nets or anti-malarials, and what the distributional effects of that are is really important and valuable. I think that should come into those value for money decisions that donors are making, because it's not just about average coverage. We're also interested in what happens to the poorest.
Yeah, exactly. And to take that and link it up to Ruth's question earlier, one of the ways that you could use this, should you decide to bring it into this comparative, multi-country kind of evaluation that you would do, is maybe in each of these countries you're doing bed net delivery, but you're doing it differently. This would allow you to measure the implication of choosing one way of delivering versus another, and other ways of doing that kind of comparative work.
There's a question there.
Your colleague. And just as another member of the Disease Control Priorities crew, just exactly on this point, in another application of the ECA approach, we are exactly doing that. We're comparing two policy options in the case of Ethiopia for encouraging greater utilization of obstetric surgery and actually trauma surgery for the surgery volume of the effort, in which we're comparing, for example, a universal health coverage approach where surgical services are free, that's one policy option, versus an option that says people still pay out of pocket, but actually what we've done is we've trained non-physician surgeons. And then, of course, we have an option that combines the two. And seeing the incremental benefits in terms of health, but also financial protection across the income spectrum has been very illuminating. And actually, there's some interesting trade-offs between health and financial protection when you do that.
Can I add? I'm
Yes,
sorry,
please,
Martin, I know you're
yeah,
probably
go
trying
ahead,
to clip it.
please.
Just to add one little note to Margaret's example, a different example in South Africa, we've looked at salt reduction. The government has put in place a policy to reduce salt in manufactured foods. And one of the interesting, surprising findings there is that the financial risk protection is fairly substantial, mostly for the richer people who are the ones who are paying for treatments, but also to the government, because the government is subsidizing low-income people, well, everybody except the rich. So by averting strokes and ischemic heart disease, the government is saving a lot of money. So we can show financial risk protection benefits and how those are distributed as well.
Yes?
I want to revert to the question of combining methods. And the thing that struck me when, Charlotte, you were presenting in particular, was a mixture and the balance between making assumptions and drawing on existing knowledge and evidence. And you said specifically in the case of sex workers, there was enough of a body of evidence around, you could feel confident about that. But more generally, I would have thought that the strength of the models must rest not merely on the calculative power of the equations and whatever other work you put into them, must base on how realistic the assumptions and the knowledge base is. Do you see there being some scope for linking with other kinds of researchers, or indeed saying that in order to prepare a model of the kind that I would like to prepare, I need this other kind of information? And is that part of a more integrated view of how methods might be mobilized than simply saying, I do this, other people do that, and isn't it interesting? What struck me very much when you were talking was the implications of what you're doing for others. I wondered whether you thought anything about that.
Yeah, I mean, it's an issue actually that we keep on trying to pursue, but actually find it quite hard to get funding for because I do think quite centrally, actually, the way that we're going to evolve, the way that we model is to develop stronger links with sort of social epidemiologists, social scientists, to help us sort of really unpick some of the and challenge some of the underlying assumptions in models. So there's sort of different layers of transparency and lack of transparency in the way that we think about modeling, for example, that we have these boxes and we essentially assume this is the way that sexual networks are structured. You know, to revamp that needs data. We've had some attempts at doing that. So we've just done a piece using data from West Africa to try and see what might be the role of transactional sex, for example, in helping to explain the variation in HIV prevalence that we see across West Africa. That's something that classically doesn't go into the standard transmission models of the region, but when we look at the sort of, we've just finished a piece of ecological analysis where actually the size of the adolescent sexual population who's having two or more partners is one of the main variables that explains the variation in prevalence. So I think that sort of interface of critiquing, sort of unpicking what are the underlying assumptions and actually looking at real data, both quantitative and qualitative, to say actually are they valid, and what if we change our model, does that give us different projections, is an area that would be nice to move forward. But funding-wise, it's going across disciplines, and that can be challenging.
We'll take one more burning question. If not, very informative, the meeting, different methodologies. I think they're very fruitful discussion between the candidates. I'm not going to try to summarize it. So thank you all very much for your contribution, and thank you. And all process due.